That's the last of the material that's going to be on your next physiology exam. So up to through circulation, what we're doing Friday, lymphatics and immunity, is going to appear on the last physiology exam. Okay, so today's material is going to be the last of what you'll see on exam 2 next week. And Friday, I'm going to try to at least give you guys, if it doesn't happen, don't kill me. I'm trying to do this. Give you some kind of summary, like, all right, this is what you need to focus on. And you have it recorded, so like, hey, you recorded that shit. Like, it's real. Like somebody else has stated in this class, I just don't sleep. Because who needs that anyway? All right, so this is the second part of the circulatory system, or the cardiovascular system, rather. So this is specifically circulation. And we've already talked about the heart and how it circulates blood, and you guys already had the question. Arteries go away from the heart, veins come back toward the heart. All right, so this is just a schematic of what that looks like. The only thing new to this is that your systemic circulation contains about 84% of your blood volume, which is most of it, right? That makes sense. Pulmonary only contains about 9%. All right, and the heart contains about another 7%. Does that add up to? Yes. So that adds up to 100. So that's where all your blood is essentially located. I'm not going to go like arteries hold 13%, whatever. But what I do want you to realize, and we're going to talk about this later on, is that your veins hold most of the volume, like almost all of the volume, in fact. All right, so we've talked about this. This is just a summary slide of what arteries do. We didn't talk about arterioles yet. So as blood vessels go on, they get smaller, and they branch, and they get, that's a shitty drawing, and they get smaller and smaller, all right? Just before they enter a capillary, they're called arterioles, all right? So that is, we call those our resistance vessels. So when we clamp down on arterioles, that's one of the things that drives up blood pressure because we have so many of them. Capillaries, of course, are exchange vessels. Venules are like arterioles, only going back to the heart, very low pressure. And veins are like what we refer to as blood reservoirs. All right, structure of arteries and arterioles. Actually, the structure of arteries, arterioles, and veins and lymphatic vessels are all the same. They have all the same layers. We have this tunica interna, which is basically a single layer of endothelial cells, which are like epithelial cells, only they are inside of blood vessels. Smooth surface to prevent friction. You also see it called the Intimal Layer. So if you hear of something called, this is always, somebody did research on this at UT, Neo-Intimal Hyperplasia, which is basically when they put a balloon catheter in and then they take it out, that triggers these cells to divide and they actually form a blockage. Some people have a genetic predisposition to that. So they're looking into who has this genetic predisposition, who doesn't. That way you know who you can do a balloon stent with and who you can't. So that's kind of cool. Tunica Media is the muscle layer. All right. In arteries, it's going to be really, really thick. All right, because arteries need to maintain pressure. Also has a lot of elastic tissue in it. All right, as well, because not only do arteries constrict to maintain pressure, but they have that elastic recoil, so when pressure increases, feel your pulse, right? You feel that bounding. Every time a pulse goes through there, that's your artery stretching, all right, because of that elastic tissue. And then outside we have the tunica externa that holds everything in place. All right, capillaries will be our smallest blood vessels. Of course, they are a single layer, just a single layer of endothelial cells in most cases, with a basement membrane surrounding them. Of course, we know already, we talked about the capillaries in the kidneys with the glomeruli have a very specific structure. They have these fenestrations within them, and then they have the slit cells, the podocytes on the outside. But not all capillaries are like that. Most are like these continuous capillaries, okay, where they have a single layer of cells and a basement membrane surrounding them. Other places, like the liver or spleen, they're really leaky. And if you notice the difference between a continuous capillary, which only has like pores every so often to let things out, these sinusoidal capillaries have large holes in them to let big things out. Because what does your liver do? What does your spleen do? They process cells, so it needs to have a good way to let cells out instead of just things that are dissolved. All right, so capillaries will be our exchange vessels. And then veins and venules look very much like arteries. The difference, though, is that they don't have a very thick muscle layer, which means they don't contract, which means they stretch out and hold volume. All right? You guys saw on the leg upstairs, I asked many of you, which is the artery, which is the vein. The vein is kind of floppy, right? The reason why it's floppy is because it doesn't have that thick muscle layer. All right? That's what makes it floppy. Whereas arteries do have that muscle layer, and that's what makes them very rigid. All right? Especially where gravity is concerned, like in the legs, veins also have valves because they're under really low pressure and there's going to be backflow, but you don't want it to backflow back into the heart. We have valves to prevent backflow from going in the opposite direction so that you have a unidirectional flow. Okay, so veins also have valves. You'll see that lymphatic vessels have valves as well because they are low pressure tubes. All right, so what is blood flow? Volume over time, flowing through a vessel. How much volume over a period of time is flowing through a vessel? Okay? Usually expressed in milliliters per minute, sometimes can be expressed in liters per minute, but typically you won't be pumping liters at a time. All right, mostly we have about 5 liters in our circulation, so our entire blood volume pumped is 5 liters per minute, which is our cardiac output, which negates everything I just said about being milliliters per minute, right? I'm glad you're listening. That was just a check. So milliliters or liters per minute, depending on what you're talking about. All right, so 5 liters per minute, that's our cardiac output. How would we express that in milliliters per minute? 500. Pardon? 500. Not 500, 5,000. All right. Don't confuse that with velocity. All right, we'll see in a few minutes about different types of flow. Velocity is the speed at which blood flows. All right, so that is different. That's distance over time. How far is blood traveling? You tag a blood cell. How far did it travel over a period of time? So that's velocity. You want good flow at a decent velocity that's not too fast or too slow. All right, so your cardiovascular system is set up so you have a nice flow, nice even flow that's not too fast. Because we'll talk about what happens if you get too fast. All right, to satisfy one of your IOs, if you puncture, if you cut an artery, artery's under really high pressure. So what's going to happen? It's going to squirt out, right? It's under high pressure, so it's going to have basically squirt out. If you cut a vein, veins are under low pressure, so what's it going to do? It's kind of ooze out, all right? So that's two ways you know if you hit an artery or hit a vein. One, the pressure versus just flowing out. Two, arteries, they are oxygenated, right? Oxygenated blood, if we're talking systemic. So they're also going to be, the blood's going to be bright red. Whereas veins, it's going to be kind of darker red, really dark. So as providers, you get somebody who comes in and they're like, I cut myself. And they take it off and they're like, and you get blood in the face. I don't want to be a PA anymore. It's probably an artery, right? If it's oozing, it's a vein. Most likely they're going to be veins. And capillaries, very similar to what veins would do because they're really low pressure and they're just going to kind of ooze. All right. In your circulatory system, despite the fact that your heart is pumping and it's pulsatile, the flow is what we refer to as laminar flow. All right, and laminar flow is a smooth, silent flow where it has like a cone in the center where things are moving the fastest, and then it's slow along the periphery. All right, a nice, even flow. You guys ever seen those videos on, I see them all the time on YouTube, and my kids show me this stupid TikTok shit, where they tape a balloon full of water, and then they puncture the hole in the middle, and you get this like nice stream that comes out. That's laminar flow. If you haven't seen it, look it up. Look, balloon puncture with tape. So that's laminar flow. That's what you should see. That's what you want in your blood vessels. If you don't have laminar flow, you have the opposite, which is turbulent flow. All right, and turbulent flow is not this nice, even columnar flowing. It's like all over the place. That's bad. That's bad. One of the major reasons, two reasons it's bad. One, it promotes clotting. Turbulent flow will clot quicker. And turbulent flow damages your blood vessels. All right, so when we have turbulent flow in an area, which is typically when blood is too fast, you're pumping too fast, when you have sharp turns in your circulation, or when you have like branching points, like your common carotid artery that splits into your internal and external carotids, those are branch points. Turbulent flow happens there. Rough surfaces in your circulation, which could happen if you have blood vessel damage, or rapid narrowing of blood vessels. So you remember that when we talked about what did we talk about? We were talking about blood.
The heart?
Oh my God. My brain just did one of those. Whew. Hemostasis. Clotting. Jesus Christ. The vasoconstriction. Like if that happens all of a sudden, that will cause turbulent flow. All right, and you can hear these as bruits. So remember in clinical correlations when you talk about listening for bruits in your renal arteries, in your aorta, and in your carotids, you shouldn't hear bruits. You want that nice laminar flow that's silent. If you do hear bruits, that's bad, right? So you don't want to hear bruits. If you are hearing bruits, you need to get your patient a big workup. All right. This I think is cool. This shows you what laminar flow looks like, and you'll see. All right, this is a tube with fluid. All right, and they have a stream of dye going through it. It's going to look like a piece of paper with just a line on it. But watch what happens when they speed up the fluid going through this tube. So this is nice laminar flow. Getting faster. Now you see the dye start to come apart. All right, this is where you would hear a bruit at this point. Okay, this was for some like civil engineering thing, but the point got across. All right, so kind of showing you what laminar flow is if you don't like the balloon example. All right, you don't want that to happen. All right, in terms of blood flow through the body, there's a lot of variation. All right, your brain receives about 14% of our blood, which translates about 700 milliliters per minute. And that's what these two show, the percentage versus milliliters per minute. On the right here, we show milliliters per minute per 100 gram of tissue. What that does is it normalizes. So if you take 100 grams of each tissue, how much blood flow are they receiving? So like everything is compared evenly then, right? So if you look at this, the kidneys receive, kidneys and liver receive most of our blood flow if we're talking about milliliters per minute of cardiac output. But if we normalize, back up. So, and then if we look down here at the glands, thyroid and adrenal, they receive about 50 and 25 milliliters per minute. So it seems like they're receiving less blood, right? But if you look at that compared to the amount of tissue, the adrenal glands are receiving about as much flow as the kidneys are, if you look at it per gram of tissue. And that's really, really important because what do glands do? They secrete hormones, and those hormones have to go into the blood, so they really need a high amount of blood flow. But you can't just bombard them with like a waterfall of blood, right? So looking at just milliliters per minute can be a little bit deceiving. If you look per gram of tissue, some receive more blood than you think they receive. All right, so that's, again, you don't have to know the numbers, understand that concept though. All right, so what determines blood flow? All right, Q is blood flow. Remember VQ? All right, so Q is blood flow. And it's a function of a difference in pressure over resistance. So two things determine it, pressure and resistance. So fluid flows from what kind of pressure to what kind of pressure? High to low, like everything. High to low, goes from high to low. So this is, let's say this is 120 millimeters of mercury, and this is 80 millimeters of mercury. Blood's going to flow in that direction. All right, so we have a pressure gradient throughout our circulatory system which drives flow. Does that make sense? The other thing that determines flow is resistance. So how much resistance do you have to blood flowing to an area? And that's usually determined by the size of the vessel. All right, larger vessels, very low resistance. Smaller vessels, very high resistance. How can you make a large vessel have more resistance? You know, say it. Squeeze it, constriction, right? So vasoconstriction can increase the resistance in a vessel. And we haven't directly gone over this yet, but what's the number one way we can normal physiologically constrict blood vessels in our body? No. Nervous system. Begins with an S. Rhymes with pimpaletic. Sympathetic. Okay, so sympathetic discharge can increase the amount of resistance in a blood vessel. And we'll talk about how that's regulated at the end of this today. All right, so that's blood flow. Remember, we have arteries, which are high pressure, veins, which are Low pressure, so blood's going to flow from arteries to veins simply because of that pressure difference. All right, so what is blood pressure then? Blood pressure is a measurement of how much force that blood is exerting on the blood vessel wall. All right, how much force the blood is exerting on the vessel wall. And of course, we measure it in millimeters of mercury, mmHg. You guys, that's how we do blood pressures, right? 120 over 80. Okay, blood pressure is a function of cardiac output. We've talked about this, right? Cardiac output. The new thing we're adding is peripheral resistance. All right, but we know cardiac output is a function of stroke volume and heart rate, right? How much blood you're pumping per beat and how many beats you have per minute, which gives us a volume per minute, which is our definition of flow. Okay, so at the end we have stroke volume times heart rate times peripheral resistance. So blood pressure looks very similar to what? Flow. Right, so blood pressure is what drives our flow. All right, so what does blood pressure look like in our circulatory system, and how does that apply to flow? You've seen graphs like this before, where we have our left ventricular pressure, which should be the highest in our entire body, versus aortic pressure. Notice that ventricular pressure, when relaxed, approaches zero. So when it's relaxed, like there's almost no pressure in there because you need it to fill up. But aortic pressure, what do you notice about its baseline? It's much higher, right? Its lowest point, the lowest point of the lowest pressure in the aorta is going to be when the ventricles are relaxing. So why is that pressure build up? Because you close the aortic valve, right? So that pressure is going to still continue to be in that vessel because you closed the valve and didn't let it flow in back into the low pressure environment of the relaxed ventricle. So it's going to be a little bit higher. And then it goes up to 120. So what this says is that when we're measuring pressure in our circulatory system, we're measuring the pressure in the blood vessels peripherally, which matches what's happening in the aorta. All right, systolic pressure is always going to be about 120, should be about 120. As providers, is 120 over 80 a good blood pressure? No. That's actually considered pre-hypertensive at this point. So you actually want blood pressures that are a little bit lower than 120, a little bit lower than 80. Okay? Which is the more important one to look at? Do you know? Diastolic. Diastolic is the more important to look at because if diastolic is high, that means your heart isn't relaxing. You got to do something about it. All right, what do you notice about pulmonary circulation pressure? This is 0. It's lower, right? So does it take as much pressure to pump to pulmonary circulation as it does to systemic circulation? No, that's the point that this is trying to show you. So high pressure in systemic circulation, low pressure in pulmonary circulation. All right, what this chart right here shows you is that if you start in the left ventricle right here, pressure is the highest, aorta, I can't see what that says because it's blurry. What does it say? Large arteries, small arteries, arterioles, capillaries. Okay, so in the capillaries, where's your pressure? Close to 0, right? It's not going to be 0 because if you have 0, you're not going to have any flow, right? So very low pressure. And then as you go back to the heart, you gain a little bit of pressure, and then it goes back to very low. All right, so it's this pressure difference between the left side of the heart and the veins that drive that flow of blood. What's one of the reasons why pressure drops here? Do you think? I've already given you the answer, but I didn't state it in these terms. Pardon? Part of it's resistance. Distance, resistance, and what's another one? What happens as you go farther away to the arteries? So you have your abdominal aorta, and they get smaller because they are branching, right? So if you take 100, let's do it this way. If you take 100 millimeters of Hg, 100, all right? It's not quite this simple, but this is just to get a point across, and split it, right? And then if you branch again, the more you branch, the lower the pressure is going to be, all right? And it's important to have low pressure in the capillaries where flow is really slow because exchange. Good. All right, one of the things driving the low pressure in the veins to help draw the blood towards them is that veins are very distensible. So as they fill with blood, instead of having that rigid wall that's going to maintain a high pressure, they blow up like balloons. Right? They're very distensible. They have a large amount of C word, rhymes with snapiance. Compliance, right? Veins are more compliant than arteries are. So here's that freaking word again, compliance. All right, veins are more compliant, so they hold a larger volume, and because they hold a larger volume, the pressure is going to be lower. All right, we talked about blood pressure already. Systolic pressure is 120 millimeters of mercury. Systolic pressure is when the left ventricle is pumping. Right? And it's pushing blood through. So that's when the highest amount of pressure is going to be in your arteries, when the ventricle is pumping it out to the arteries. All right? We measure that as 120. When the ventricle relaxes and blood flows backwards and hits the aortic valve, right, because that's why you have the valve, so it closes, that's our diastolic pressure when the ventricle is relaxing. So that's going to be lower, obviously, because you're not physically pumping things out. That's about 80 milliliters of mercury. So that's where our pressure, diastolic, systolic, our blood pressure is derived from. All right? The difference between those two is known as our pulse pressure. The difference between the two is our pulse pressure. So if we have a systolic pressure of 130 and a diastolic pressure of 75, what's our pulse pressure? 55. Okay? So you'll see that term come up. I just want to make sure it's explained. You know what pulse pressure is. It's that pressure difference between the two. What affects pulse pressure? Well, a few things. One is cardiac output. How much is your blood pumping out per minute? All right, so that's obviously going to affect how high the pressure is. Peripheral resistance. Is that going to increase pressure or decrease pressure? If you have increased peripheral resistance, is that going to increase or decrease pressure? Increase. So if I take a tube like this and pump through it, it's going to be pretty easy. But if I narrow the tube, it's going to be harder to pump through that tube. So the pressure is going to be higher. All right? Specifically with pulse pressure, what determines that is stroke volume. So how much blood you're pumping out per beat. and arterial compliance. If our arteries are really compliant, what's going to happen to pulse pressure? Okay. So one of the things related to this is something called mean arterial pressure. And if you have ever been in a hospital and look at the monitor that they have, they'll have something up there called MAP, mean arterial pressure. The equation for that is down here. So I've given you a few equations now. The blood pressure equation, right? Know that. I've given you the, what's the other equation I gave you? Pulse pressure. Duh. And mean arterial pressure. I will have a question about these, I'm pretty sure. All right. Mean arterial pressure is your diastolic blood pressure plus systolic minus diastolic over 3. So diastolic BP over, I'm sorry, not over, plus systolic BP minus diastolic BP over 3. Okay, that's how you figure that out. That's your mean arterial pressure. And the importance of your mean arterial pressure, which is basically the amount of pressure that's throughout your entire circulatory system in the arteries, is how well your tissues are perfused. All right, it's an indicator of how well your tissues are perfused. And what you want to see is a normal mean arterial pressure somewhere between 70 and 100. All right, if you see a mean arterial pressure under 70, what does that mean? Pardon? You're not getting enough blood to your tissues, right? If you're talking about the brain, which is where this really comes into play, you're not giving your brain enough nutrients. And what's it going to do? Shut down. Okay? So you want mean arterial pressure. What happens if your mean arterial pressure is like 120, 130? Like, it's perfusing great. Like, why don't we crank that shit up to 500? We could blow out vessels, like especially at the capillary level. You see capillaries bursting. You could cause turbulent flow, which would damage your blood vessels and cause a whole host of other problems, including clot formation. What's wrong with your arm? Okay. Random. I know. He's trying to keep up his mean arterial pressure. So this is kind of what we call a sweet spot, all right? You want it to be in a certain range. If it's too low, you're not perfusing. If it's too high, you're still not perfusing, right? Because it's you get into that turbulent flow. So that's why we discuss laminar flow versus turbulent flow. Too high, you get that turbulent flow, causes damage to blood vessels. All right. So what kind of things affect blood pressure? We've kind of mentioned these already. Cardiac output, you know the equation. Compliance, the elasticity of vessels, that will affect blood pressure. The more compliant they are, the lower the pressure. Blood volume. If I increase blood volume, what's that going to do to pressure? It's going to increase pressure, right? Increased volume is increased pressure. That makes sense. Except when you're talking about air in the lungs, right? That's actually going to come back this lecture. Like, shit. I thought we got rid of that. Blood viscosity. What does that mean? How thick it is. All right. You guys can do whatever you want. A pet peeve of mine, and your patients are going to understand certain things. The only thing that makes your blood thin is water. More volume. right? So when you take blood thinners, you're not thinning your blood. You're preventing coagulation, right? Not everybody understands that, so we call them blood thinners. That's just one of those pet peeves, like, you're not thinning your blood, stop it. All right, so blood viscosity. If we have thick blood, so for example, if we have like polycythemia, too many red blood cells, if we have a dehydration situation where blood gets thick, pressure goes up because it's harder to push. It's harder to push motor oil than it is to push water. All right, and also blood vessel length and diameter. If we have longer and narrower blood vessels, we have a greater resistance. If we have a really short blood vessel, very low resistance. If it's really wide, really low resistance. All right, so these graphs show you kind of across the circulatory system where we have arteries on the left and veins on the right, what happens to certain parameters as you go across the circulatory system. So here, vessel diameter, I think that's what that says, vessel diameter. All right, you start at the aorta, you get to capillaries, you go back up to the vena cava. That makes sense, right? Okay, so blood vessel diameter. Cross-sectional area. All right, the cross-sectional area of our arteries, very small, right? But as those arteries spread out and we get to the capillary level, we have a large cross-sectional area because we have to find a way to get blood in the aorta out to every possible tissue. So that's the branching effect. All right, then Nulls Capillaries, we have venules, veins, and we get back to a relatively low cross-sectional area. Right, it's a similar thing. It's a similar concept. You're increasing surface area, right? Cross-sectional area. Like when we emulsified fats to create the surface area so lipase could get at them. Here we're increasing surface area so we can have more diffusion and exchange happening. All right. Average blood pressure. We've seen this already. Highest at the level of the aorta, lowest at the level of the vena cava. In fact, blood coming into our vena cava is almost at zero. Or our right atrium, rather, is almost at zero. So it's almost like it's like being pushed up and kind of just flowing in. I need to find a good video on that. All right, and finally, this last one, velocity of blood flow. How fast is it pumping? Of course, because you want to maintain a high blood pressure, blood's got to be pumped pretty fast when you're at the aortic level. But as blood vessels branch, velocity drops. You get into the capillaries here, that's going to be the lowest velocity because you guys already said exchange. And then velocity is going to increase as you go back to veins. If veins are under such low pressure and they don't have a pump driving that fluid, how do they pick up speed? Pardon? There's a vacuum effect. All right, we'll talk about that vacuum effect. That's with the thoracic cavity. And also what I'm doing right now. Besides holding my chest, I'm walking around, right? Skeletal muscle pump. That helps push fluid back through the veins. All right, so all of our tissues need blood flow, right? Because we have to get oxygen out, we have to get nutrients out, we have to pick up waste and deliver them back to where they can be gotten rid of. All right, but each tissue has the ability to control its own flow depending on what it needs. All right, each tissue has its own control in proportion to what it needs. That's what we call local control. All right, so we're talking about if a tissue needs oxygen. If we start running, what tissues are going to preferentially need more oxygen? skeletal muscles in our legs. All right. Nutrients. Getting rid of I already said all this. All right. As well as transporting hormones. All right. So if So flow is basically, local control blood flow is based on the metabolic needs. So we say tissue controls blood flow in proportion to its needs. Its needs are metabolically related, right? So if a tissue is more active, it's going to need more blood flow, period. All right, there are a couple theories, and when we say theories about local control blood flow, what we mean is they've observed this in the laboratory under certain conditions, but they don't know how it is actually working in the body. Okay? So when we say theories like this, it could be this or it could be this. We don't know for sure. All right? Two possible mechanisms: short-term control of blood flow, acute control of blood flow. All right? The vasodilator theory and the oxygen demand theory. All right? If I were to say, hey, know the oxygen demand theory, and I never explained it, do you think you could explain it? Yeah, it makes sense. It's all explained right there. If you need more oxygen, you're going to get more flow. But the vasodilator theory doesn't make as much sense. So we'll go over both of them. All right, the vasodilator theory goes like this. If we have an increase in tissue metabolism, I go running, or I start walking around the room. That's going to cause the release of vasodilators from tissues that are more active. That's going to decrease the resistance of the arterioles in that tissue. Remember, here's your arterial. Here's our capillaries, right? This is our capillary bed. Here is a precapillary sphincter controlling entry into the capillary. So what this says is that we release vasodilators. This opens up and allows more blood to go into the tissues. Does that make sense? Okay, so that's the vasodilator theory. So this muscle cell out here would release those factors. All right, so you have an increase in blood flow. What are some of the vasodilators that could be released? They're listed down here. The oxygen demand theory makes sense, right? If you have a more active tissue, you're going to need more oxygen, right? So, but that's not the whole story. Let's put it this way. If I have decrease in oxygen to these tissues, we're going to want to increase oxygen to those tissues, right? So what these cells will do is they'll tell these precapillary sphincters to dilate and here so that we get more flow. So instead of releasing vasodilators because you have a more metabolically active tissue, lack of O2 is driving this. Does that make sense? Now you could argue that because it's lacking O2, they're releasing vasodilators to open up those sphincters, right? But they can happen independently of each other. All right? That's why there's two theories. So, both of these, again, local level to explain acute control of blood flow to a tissue. Then we have long-term control. All right, long-term control is what we call autoregulation. All right, and autoregulation of tissue blood flow is based on something called the metabolic theory. All right, the metabolic theory says, hey, when there's a decrease in arterial pressure, for whatever reason, some of the reasons are there, like let's say you have a heart attack and you're not pumping blood, pressure drops, okay? Your tissues aren't going to get enough oxygen or nutrients. Because they're not getting enough oxygen or nutrients, they're going to release vasodilators to open up precapillary sphincters. Now, that sounds very similar to short-term regulation theory, right? Because you're releasing vasodilators. What's the difference between the two, though? Nobody?
Oxygen causing?
No. It's a global decrease in arterial pressure as opposed to a local decrease in oxygen in a tissue. Right? It's a global decrease. So this would happen throughout our entire body. All right? So, metabolic theory says decrease in arterial pressure, you have decreased oxygen and nutrient delivery, and those tissues globally are going to release vasodilators. So you have a massive vasodilation. Okay? But autoregulation goes two ways. So what do you think happens when there's an increase in arterial pressure? Like hypertension. If you're thinking just the opposite, you're right. All right, just the opposite, right? Basically, if you have an increase in pressure, you're not going to release these vasodilators. You're going to stay constricted, right? Because you don't want all that high pressure to get to the tissues. Because what's that going to happen? What's going to happen? You're going to cause damage, okay? But there's another theory. Like, seriously? All right, so to help you guys unpack these, think of them as short-term regulation. Think of leg muscles when running. Okay? That's short-term local regulation. Long-term regulation is a global effect. All right? So you have two theories that are short-term, two theories that are long-term. All right? When there's a decrease in arterial pressure, and by now you guys, because I'm thinking this too, so I know you're thinking it, like all this shit sounds the same. There are subtle differences. When there's a decrease in arterial pressure, the arterioles intrinsically dilate. What's missing here? Vasodilators. So when there's a decrease in arterial pressure, arterioles intrinsically dilate in response to decreased wall tension. So we have a blood vessel here. Blood pressure drops. So instead of maybe stretching your arterioles like that, they are only stretching out this far. All right? What that means is that you don't have enough pressure to get to the capillaries. So the capillaries are going to go, hey, we need to open up these arterioles to let more in. Right? So they're going to recognize that and automatically dilate without any input from vasodilators from tissue. Okay? So that's the myogenic theory. What does myo mean? Muscle. So generated from the muscle itself. As opposed to the metabolic theory, which means tissues are starving, they're releasing vasodilators. All right, so what happens if there's an increase in tension? What happens if I'm stretching out this far? What are those arterioles going to do that lead to capillaries? They're going to constrict, right? because you have more than enough pressure to get blood to the capillaries, but you don't want it to be too much. So you constrict those arterioles so that you don't damage the capillary beds. All right, so two ways to do things. Even though I give you the example of decrease in pressure, this can also happen with an increase in pressure. So just the opposite. So unpackage that when you guys are studying. If you're like going, what the fuck right now? Seriously, go over it and you'll be like, okay, I got it. And if you still have questions, I'm available. All right? Turns out long-term regulation is more effective than short-term regulation. Duh. All right? It's the difference between putting a Band-Aid on a problem versus fixing the actual problem, right? So, long-term local blood flow. Oh, basically what this is, other long-term regulations. If you have a decrease, let's say, let's say you decide to pick up running all of a sudden. You never ran in your life, and you pick up running all of a sudden. Compared to what your body needs when you're running, you don't have enough blood flow to your tissues, right? So that's why when you run for the first time, you're like, I'm never doing this shit again, right? Because your body hurts. It's not getting enough blood flow. So your body's going to take that as oh crap, I need to do something about this because he's probably going to run again at some point. All right? So instead of controlling it through the mechanisms we just talked about, one of the other things it can do over a long period of time, so you're running like, this is your third month running now. By this point, what you've done is you've increased the vascularity of tissues. In other words, your muscle tissues that are involved in running, as well as your respiratory muscles, are saying, hey, this is going on for a long period of time. He's running every fucking day. How are we going to manage this? All right, let's put some new blood vessels in the muscles. Right? That's what we mean by an increase in vascularity. So this process of angiogenesis is going to occur. Angiogenesis means making new blood vessels. And then what's going to happen? You go running on that first day after the third month, and you're like, hey, maybe I can do this. My legs don't feel so bad anymore. Why? Because you're getting more blood flow, because your tissues responded by making new blood vessels. Does that make sense? So over a long period of time, this isn't going to happen overnight, because growing new blood vessels, growing anything in our body, takes a long time. That's a long-term response. So what happens then if you blow out your knee? I'm not talking from experience here. And you can't run anymore. What's going to happen to your leg muscles in terms of vascularity? It's going to go away. Like you lose that. All right? So your body regulates to what it needs. If it needs new blood vessels, it's going to grow new blood vessels, because those tissues are going to need more oxygen. If you're not using it, you're going to lose it. Okay?
When you have these new vessels that are grown, they're like smaller, right? Like you're not growing another femoral artery.
No, you're not growing another aorta. No, they're at the microvascular level. Good question, though. That'd be really weird. Like, yeah, I got two aortas. All right, so this is just showing you angiogenesis. What this picture shows you right here is this is a rat muscle, and all these little white dots represent capillaries. What they did was a couple times a day, they stimulated this rat muscle to contract, like exercise, and after 3 months, this is what their capillaries look like. So all those little white dots represent capillaries. So after 3 months, did you double your amount of capillaries? No, I don't know how many that is, but it's not. It's like 3 or 4. It's like 10 times more blood vessels. So very robust response. Okay. What triggers this? Tissue's not getting enough oxygen compared to the need. Okay, compared to the need. Rapidly growing tissue. So little kids undergo puberty, go through these growth spurts. More muscle means I got to have more blood to that muscle, so angiogenesis is going to occur. Okay. Tissues with high metabolic rates, like muscles, for example, are going to have more capillarity. All right. And these are driven by growth factors: vascular endothelial growth factor, fibroblast growth factor, a protein called angiogenin. All right. So these are released by the tissue that's being stimulated to the blood vessels to say, hey, grow some more of yourself. We need more oxygen. We need to get rid of more waste. Okay? All right. Hormonal regulation of blood flow. In other words, there are factors in your body that regulate blood flow to certain tissues under certain times. And there are ones that can decrease blood flow. Those are your vasoconstrictors. There are those that can increase blood flow. Those are your vasodilators. All right. So here's a list of vasoconstrictors. Here's a list of vasodilators. You should know the difference between the two. All right. We've already talked about the sympathetic nervous system constricting blood vessels, right? Which one of those up there is related to the sympathetic nervous system? Norepinephrine, right? Histamine, we know, is a vasodilator that's involved in the inflammatory response. What happens in the inflammatory response? You have more blood flow to an area because you are increasing you're vasodilating the blood vessels leading to that area. All right? So this is more of one of those, if I put one of these on a question, you should know what it's doing. I said your tissues release serotonin in response to yada, yada, yada. What's the effect going to be? Or something does that make sense? Something to that effect. All right. I don't care that you know specifically when bradykinin is released or when angiotensin II is released, although you do know that by now. All right. When's angiotensin released? 2. I don't remember. Remember, decreased renal blood flow, decreased sodium. All right. So, microcirculation. Where's that going to happen? Arterioles, capillaries, venules. What's the function? Delivery of nutrients to tissues, removal of wastes. All right. So when we talk about microcirculation, can you see it? No, you can't. This is all microscopic. That's what microcirculation means. So there's over 10 billion capillaries in our body, even though it doesn't seem like that. You can't see them, with a surface area of 500 to 700 square meters. That's huge. Right? Increased surface area, increased delivery, increased picking up of wastes. All right? And it all occurred because these arteries got smaller, branched out, blood got slower. All right? All right. Capillaries. We've already talked about capillaries. Yeah. Jesus. All right, what does a capillary wall look like? All right, remember, capillaries are a single layer of cells. Okay, these are 2, 3 cells, actually. 3. all right, endothelial cells, and they have these clefts between each one of the cells. All right, so one of the hallmarks of a capillary is it has clefts between the cells, and the reason you have clefts is so that you can exchange things. All right, so things can cross these clefts within capillaries. Put them here. But I do want you to know that if we want something to get out of the blood and into the tissues, these capillary cells will also endocytose. That's what this is showing. They'll endocytose something, let's say sodium, bring it through the cell, and release it on the other side, exocytosis. Okay, so that does happen in capillaries as well. All right, how do we exchange things across a capillary? What's the driving force? All right, the most important driving force is diffusion. Define diffusion for me. Right, something moving from high to low concentration. You have a high concentration of something in the blood, you have a low concentration of something in the tissues, it's going to go whoosh. If we're talking about peripheral tissues, that's the way oxygen and carbon dioxide work, right? They diffuse across the capillary. So that's going to happen readily. That's the most important part. As well as lipid-soluble substances, they will go right through. Like if you have less of a substance in the tissues, more in the blood, it's going to diffuse right through. Lipid-insoluble substances go through those clefts, or they go through that vesicle pathway. All right, and of course, if diffusion is the primary mechanism, then it's concentration differences across this capillary wall that's going to drive it. Okay? Let's take a break. Let's take 5 because I need it. And I know you guys do. What is in there?
Peaches.
Just get this finished. And I'm behind where I want to be, so let's go really fast. Actually, I will abbreviate things. Basically, what this slide is saying is that what's going to pass through the capillary pores is what can fit through the capillary pores. So if we're talking about inside of a capillary, you're going to get ions through, you're going to get very small proteins through, you're not going to get cells through, and you're not going to get large proteins. So everything gets filtered out, stuff gets left behind. Okay, that's talking about the arterial end. At the venule end, stuff gets in, but like large proteins can't get back into the capillaries as well. So you got to consider both sides of the capillary, the arterial end and the venule end. All right, what are you really exchanging with? So the capillaries are scattered throughout what we call interstitial tissue. All right, and bless you. We like to think of interstitial tissue as like this fluid space, but really it's like a jelly space. All right, it's more like a jelly space. So it's not as fluid as you might think. So things aren't just like flooding out like a dam. It's a slow exchange. All right, what determines what gets out of a capillary is fluid movement, and that's determined by 4 things, just like we had with the glomerular capillaries. You have blood pressure or capillary pressure pushing fluid out. You also have proteins in the interstitial fluid that are also pulling fluid out. All right? Those are your things in red, pushing stuff out of a capillary. But you also have pressure in the interstitial space that's pushing fluid back into a capillary. And you also have proteins in the capillaries that's also pulling fluid back in. So you have this pushing by pressure, and you have this pulling by proteins, osmotic pressure. All right? All of those added up and subtracted from one another, like the red's going out, the green's coming back in, our net pressure is outward. All right? So when you add all of those up, our net pressure is going to be favoring outflow. All right? So if we have a net outflow of fluid from the capillaries with nothing else going on, what would happen to our tissues? They'd swell up, right? We'd have edema. So this is why we have a lymphatic system, which we'll talk about on Friday, which picks up that extra fluid and puts it back into the circulatory system, right? Up to 90% of that fluid gets reabsorbed at the venous end. Actually, no. All right. All the fluid you're pushing out, 90% of that gets reabsorbed in the venous end. So you got 10% left over. That's what gets picked up by the lymphatics, that extra 10%, and gets put back into circulation. At what veins? Do you remember? Where does lymphatics dump back into? This is from anatomy. So left subclavian. Actually, right subclavian too, but. All right. This picture right here, or this picture, this thing right here is just basically showing you in numbers those things that we talked about in the previous few slides. So remember the red is what's pushing out. The green is what's pushing back in, or red coming out of the capillary, green going back into the capillary. Our net outward force is about 0.3 millimeters of mercury. All right. So net, we have 0.3 pressure pushing out. Again, I don't care that you know the numbers. It's just proof of concept. Okay, so we've done our exchange, and now we're going back to the heart. All right, so now we're going to talk about what happens in the veins. All right, 60 to 65% of our blood is in the veins. That's our reservoir. So if we ever need more blood to be flowing through our body, where do we get that from? The venous system. All right, so we're going to talk about how that happens and how we can get that to contribute to overall circulation. All right, so that brings us to a concept called central venous pressure. And you guys have heard of this right before, right? Central venous pressure. Central venous pressure is also our right atrial pressure. So in other words, if we want to measure the pressure in our venous system, we're going to put a catheter into the right atrium and see how much pressure is there. Okay? And normal central venous pressure is about 0. Why? Because you want a big pressure difference. You have a high pressure, and blood's going to flow from high pressure to low pressure. So if you have an area that's almost 0, blood's all going to want to go there, right? All right, so it's normally 0, but it can be as high as 20 to 30 millimeters of mercury. So when would we increase central venous pressure? What would increase central venous pressure? Any guesses? I thought you were going faster. All right, I'll tell you. blood flowing back to the heart, right? If I start running and I'm pumping more blood from my veins to my heart, is that going to increase the pressure in the right atrium? Of course. Is that eventually going to level out? Yeah. All right, but a temporary increase. So it can be as high as 20 to 30 millimeters of mercury, but that can also be in pathological conditions. All right. So what controls our right atrial pressure, which is central? So know that central venous pressure is right atrial pressure, because I could use them interchangeably. What determines right atrial pressure? The ability of the heart to pump blood out of the atrium, right? What determines? The ability to pump out of the atrium and the rate of blood flowing into the atrium from the veins. So our ability to pump out and the volume of blood coming back in. That's what's going to determine our right atrial pressure. So what can increase it? This is your list. Increased blood volume. We drink a lot of water. It goes through our circulatory system. That's going to increase the amount of right atrial pressure simply because there's more blood coming back to our heart. Increased venous tone. That means your veins are constricting. What would cause that? Begins with an S. Rhymes with pimpanetic. Sympathetic. I don't know why I'm pimping everything today. Dilation of arterioles. So if we open up arterioles, more blood getting into capillaries, therefore more blood's going to get into the venous system. That's going to go back to the heart. Or decreased cardiac function. If we're not pumping out, the blood's going to stay there, right? That's going to increase pressure. So if I have somebody that's in heart failure, what's their central venous pressure going to be? Is it going to be 0? Probably not. It's going to be a little bit higher. All right. So, compressional factors can cause resistance to flow in large peripheral veins. What that means is that certain things that compress veins can decrease flow back to the right atrium. So there are certain compression areas in your body, especially in the thorax region, that will prevent blood from coming back. One of them is in your jugular veins, because they are because of gravity, that causes a collapse within the neck, so that will decrease the amount of blood coming back. When you breathe, that can compress veins, prevent blood from coming back to the heart. All right, these are normal things that happen. Axillary collapse. This is why they tell you not to put crutches in your armpits, right? So that you don't compress those veins and prevent blood from coming back to the heart. Intrathoracic pressure, abdominal pressure. If our abdominal pressure is really low, that's going to compress. That's not going to. I'll explain it later. But if our abdominal pressure is low, that's going to prevent blood from coming back to the heart, because it's going to be lower than our thoracic cavity, right? Blood flows from high to low. If our pressure here is low compared to here, blood's not going to flow back, okay? So certain spots that will compress veins, preventing flow of blood back to the heart. Okay, we talked about those already. See, I told you we go faster. So, other things that can, like, prevent blood flow coming back from the heart through the veins is simply gravity, especially in our lower limbs. All right, so the weight of the blood in the veins prevents blood from coming back. This is why if you sit too long or you stand too long without moving, you tend to get edema, because that blood pools in your legs. The fluid doesn't have anywhere else to go, so it's going to seep out. Okay? All right, so that's why if you look at this guy, here is central venous pressure, 0, right? Down here, it's as high as 90 because of the gravity, okay, the weight of the blood. All right, so despite these factors that decrease blood flow back to the heart in the veins, how do we get blood flow back? How can we increase this blood flow despite all these factors working against us? Well, one thing, especially in our legs, all right, this is a misconception. Like, I teach this in undergrad, and I say veins have valves. And the assumption is every vein in your body has a valve. The truth is that's not true. Most of the valves you're going to find are in your lower limbs because that's where the biggest effect is. All right? And what valves do is they allow blood to go up, but then when blood comes back down, they close. Okay? So it's the action of blood flowing backwards that fills up these cusps and closes the valve. Where else have we seen this? Aortic, the semilunar valves, right? So the same thing, same concept. All right. We also have veins conveniently located between skeletal muscles. So that means the more we contract skeletal muscles, the more we push on those veins, the more we push blood back to the heart. And why does the blood flow in only one direction? Begins with a V, rhymes with smells. Valves. All right, we call this the skeletal muscle pump. So just me walking around, I'm getting more blood flowing back to my heart. Okay, simply because I'm compressing the veins between my muscles. All right, every time we breathe, my thoracic cavity expands. Pressure drops below what's in the abdomen. Blood goes from high pressure to low pressure. We increase blood flow to the heart. Does that make sense? So blood pressure or pressure is higher in the abdomen than it is in the thorax. Every time we inhale, blood flow increases. That's what we call the respiratory pump. Right? And I found this picture. I don't remember where I pulled it from, but just showing you that if this little guy is laying down, if you increase the thoracic cavity volume, you decrease the pressure, blood flows back to the heart. It's a lame drawing, but it works. It's better than what I could have drawn, though. All right. I don't know how much I want to get into this. What happened?
You were trying to erase the green.
Oh, yeah, I did try to erase that green. I was hoping you guys didn't notice that. I was like, why? Oh. Jerks. Factors affecting venous return. So we talked about things that prevent venous return. We talked about things that promote venous return. So some other factors affecting venous return, right atrial pressure. All right, if we have a blood's flowing back into our right atrium, okay, if we already have a lot of fluid here and a high pressure, what's that going to do to the amount of blood that can come back? It's going to decrease it. So high atrial pressure can decrease blood flow back to the heart. All right, we have high atrial pressure if we're not pumping blood out. Scenarios like heart failure or a heart attack. The degree of filling of the systemic circulation. In other words, how much blood are we pumping out to the systemic circulation? That's also going to determine how much comes back. The more we pump out, the more that comes back. That makes sense, right? It has to be that way. The more we pump out, the more we pump back. That's what we call the mean systemic filling pressure. All right. The higher the mean systemic filling pressure, the more blood comes back. All right, and I have this circled that won't erase because that's important. All right, also resistance to blood flow between the peripheral vessels and the right atrium. So if you resist blood flow back, you're simply not going to get blood flow back. So that's going to decrease venous return. Okay? What this graph shows you is, we'll back up. Another definition of mean systemic filling pressure is if, in terms of an actual number, is if we stop pumping the heart and everything equilibrates, no blood's moving, what is the pressure of the system? Does that make sense? So if we have blood just sitting there, bless you. So it's like if we fill up a balloon with water and just put it down and pop it, what's going to happen? The water's going to go out. Why? Because it was under pressure, right? So if we stop all the blood flow in our body, it's still going to be in all these vessels. It's still going to have a pressure. So if we pop it, it's going to... So the mean systemic filling pressure is that pressure. Does that make sense? Okay, the pressure of the system as if nothing's pumping. All right? The mean systemic filling pressure is about 7 millimeters of mercury. All right, so that's basically what this graph is showing you. So on the bottom here we have right atrial pressure, about 7 millimeters of mercury. And on the x-axis we have venous return. So at the way you read this, at 7 millimeters of mercury, we have a venous return of about 6 liters. Does that make sense? At mean systemic filling pressure of 7, we have a venous return of about 6 liters. That's important because of the graphs we're going to show later. Okay. What can affect mean filling pressure? Sympathetic nervous system. If we have a sympathetic nervous system, what we're doing is we're squeezing blood vessels. We're not just squeezing arteries. I mean, the sympathetic nervous system doesn't say, hey, we're just going to squeeze arteries but not veins. It's going to squeeze everything. Okay? So if we squeeze veins, we're going to have an increase in filling pressure, right? Because that's squeezing the veins and you're pushing blood through the veins back to the heart. Does that make sense? Yes? Okay. If we increase, this is normal, that's 6, right? If we increase the mean systemic filling pressure to 14, our venous return increases. So what this is saying, this graph is saying, if we increase mean systemic filling pressure, we increase the venous return. Or if we increase venous return, we increase systemic filling pressure. That makes sense. More blood coming back equals greater pressure. All right. If we have less blood coming back, we have a lower pressure. Right? Less blood coming back to the heart, it's not going to stretch as much. What do we call that stretching effect of the heart? Pardon? No. If we stretch the heart and it pumps harder, startling. Okay. All the hard stuff is done. Now this is the fun stuff. Like, define fun, asshole. Okay. How do we regulate all of this? I love the nervous system. Everyone else, what?
It's just you.
You're not my favorite cohort anymore. I'm kidding. I don't play those games. I love you both in different ways. Do what?
I said it's too late. We're here.
The ego's already inflated.
All right.
They weren't even in first game, so we're winning.
Our blood pressure is regulated by our nervous system. Our flow is regulated by our nervous system. It's regulated by the autonomic nervous system. Can you imagine if you had to think every time you wanted to raise your blood pressure or lower your blood pressure? Like, you wouldn't be here in PA school. All right? So we have to have the autonomic nervous system regulating that. The sympathetic nervous system is the important driver. The important driver. All right? Parasympathetic is also important, but it's only going to have an effect on the heart. Specifically only, and this is important, only on heart rate. Parasympathetic is only going to affect heart rate. And based on what we've learned in the heart, what does parasympathetic do to heart rate? Slows it down. All right, sympathetic then would speed it up. But sympathetic also causes increased strength of contraction. We learned that. And it also causes constriction of blood vessels. So parasympathetic, only heart rate, does not go to blood vessels at all. Okay. The only thing sympathetic doesn't innervate are capillaries and precapillary sphincters. Why? Because those are under what? No. Begins with L, rhymes with focal. Local control. Right? They're under local control, so we don't want global control over those because they need to control their own needs. All right? Danes, also sympathetic. Parasympathetic, again, only heart rate. So this is just reiterating what I've already said. Remember, we determine blood pressure by cardiac output and total peripheral resistance. The resistance is determined by what we do with blood vessels. So we can regulate blood pressure. Our sympathetic nervous system can regulate blood pressure by not only controlling what happens in the heart, but by controlling what happens in the blood vessels. Right? And it's only sympathetic that controls what happens in the blood vessels. If we send out sympathetic impulses, what's that going to do to blood vessels? Constrict or dilate? Constrict. What's that going to do to peripheral resistance? It's going to increase peripheral resistance. What's that going to do to blood pressure? Increase blood pressure. Okay? This is regulated by something in our brainstem called the vasomotor control center, or the vasomotor center. All right? It's weird because they call it the vasomotor control center, but it also controls things that happen in the heart. Vasomotor control center. All right? Has a couple areas. Has a vasoconstrictor area, which controls vasoconstriction. Has a vasodilator, which controls vasodilation. And a sensory area. So, one of these feedback loops. If we want a blood vessel to constrict, what do we have to do with the sympathetic nervous system? Pardon? Increase the activation. If we want to dilate a blood vessel, what do we do to the sympathetic nervous system? Decrease activation. So, going back to what you hate about the nervous system, if this maintains normal tone, this is action potentials being sent to a blood vessel, that's normal tone. If we want to constrict, we send more action potentials through the sympathetic nervous system. If we want to dilate, we send less action potentials. Okay? Notice, parasympathetic, not involved. Right? It's just regulated through increases or decreases in the sympathetic nervous system. Okay? So, this kind of explains what's going on with the circuitry. But what it says is if you detect that, if your blood vessels detect that there's low pressure, they're going to send a signal to the this area in the medulla, which is going to say, hey, there's, remember the sensory part, there's low pressure in this blood vessel. Let's increase the pressure. And what are they going to do? Clamp down. Okay? Increase sympathetic stimulation. All right. There are also higher, we're not going to get into this at all, but be aware that there are also higher center. Remember the brainstem. Everything that's living has a brainstem. Higher order animals. All right, not everything that's living. Every kind of animal has a brainstem. All right, that's not true either, because sponges are animals too, and they don't have brainstems. We have brainstems. Mice have brainstems. Rats have brainstems. All right? That controls life. We have higher ordered thinking. Right? But below that higher ordered thinking, that can stimulate the this vasomotor control center to increase or decrease activity. Okay? That's all that's saying. That took way too fucking long to explain. All right. How does it do that? If we get scared. I had a meeting with one of my advisees today from the other cohort. You know, my favorite now. Kidding. She's like, take your kids to Cedar Point. I can't go to Cedar Point anymore because it makes me sick. I'm getting old. It sucks. I'm going to get scopolamine patches and put them on behind my ear so I don't get nausea anymore. Anyway, you get on a roller coaster. The point is, getting on a roller coaster, one of the thrills is you get scared, right? That sends signals to the vasomotor control center, increases sympathetic nervous activity, decreases parasympathetic, increase in resistance, increase in venous return, increase in heart rate, increase in strength, increases blood pressure. What does AP stand for? Arterial pressure. That's the same thing as blood pressure. Okay? All right, so that increases blood pressure. Okay? You guys wake up in the morning. You wake up at 7:45. You look at the clock. You look at the clock and go, oh shit, I have an exam at 8. What happens to your blood pressure? Straight through the roof because of this. Okay? So that's how higher ordered thinking can increase blood pressure, right? What's tomorrow? Oh, no, you guys are fine. No. All right. But we also have reflexes. All right. We also have reflexes through baroreceptors. What do baroreceptors detect? Changes in pressure. Baro is pressure. All right. This is short-term regulation of blood pressure. All right. We have baroreceptors in two places. One is in the aortic arch, right here, and the other is in the carotid arteries, right at the branching point where the common carotid artery splits into the internal and external. All right? And that makes sense why it would be in those places, because your brain is a really important organ to control blood flow regulation too. All right? So when these areas stretch or don't stretch enough, so it responds to the degree of stretch, they're going to send signals up to the vasomotor control center to moderate the constriction of the arteries in the body. So these are systemic pressure points that regulate what happens in the entire body. Okay? Because when you increase sympathetic nervous system activity, it affects the whole body, right? All right, so signals from here go to the brain. The brain then sends signals to all of the blood vessels in the body to constrict or dilate. All right, so our carotid baroreceptors respond to pressures between 60 and 180. Okay, so that's the range in which they're going to have their biggest effect. And their goal is to maintain a constant blood pressure. All right, that's the whole goal, is to maintain a constant blood pressure. So they're constantly monitoring blood pressure. The baroreceptor reflex, sensing and sending signals back out, is most sensitive at 100 millimeters of mercury, which is about our what? Actually, it's not about our what. It's right in. It's about our mean arterial pressure. All right, so it's most sensitive there because it wants to regulate it at about that number. All right, as pressure increases, let's say in the carotid arteries, that's going to. I like pictures. Increase pressure detected here. It's going to go to the brainstem. It's going to send signals back out to all the arteries. If we have an increase in pressure, what's it going to do? You want to decrease pressure, which is going to dilate blood vessels, so less sympathetic nervous system activity. All right. It's also going to signal the vagal center, the vagus nerve going to the heart. It says, hey, pressure's too high, we need to drop it. We're going to dilate blood vessels, we're going to decrease heart rate, and we're going to decrease force of contraction, stroke volume. Okay, that's how the baroreceptor works. Good example of this. You go to the bathroom, you sit down, and you intend just to defecate, but you play this game on your phone and you're there for like a half hour too long, right? And then your kid starts crying, and you have to stand up really quick, and you get dizzy. Has anybody ever gotten up from a sitting position real quick and they feel like a little bit lightheaded? Sometimes. That's normal. Blood pressure drops when you do that. When you go from a laying down or a sitting position to standing up really quick, blood pressure drops. All right? Why don't we faint? Why don't we pass out? Why don't most of us feel this on an everyday basis? Because that decrease in blood pressure signals carotid arteries, aortic arch right away. That's going to be sensed by the baroreceptors. That's going to increase sympathetic activity to our blood vessels, so blood vessels are going to cramp really quickly, clamp really quickly. Heart rate's going to go up really quick, and you're going to feel like your heart's beating out of your chest. Like, have you felt that? Like you get up really quick and you're like, that's your body trying to increase pressure because to avoid that fainting spell. Does that make sense? Okay, so that's when going from a laying down or sitting down to a standing up position. All right. However, baroreceptors adapt. So if you have a chronic condition such as hypertension, your baroreceptors will get a new set point. So instead of operating at 100 millimeters of mercury, it's now operating at 120. Okay, so your baroreceptors can adapt to changes in pressure. Or if you're elderly and you have heart failure and you have a lower pressure, baroreceptors are going to operate at that lower pressure. So they will adapt. That's what this slide is saying. All right. Turns out that our baroreceptors are located in the same spot where our chemoreceptors are located. We talked about this when we did the respiratory system, right? Chemoreceptors detect, specifically, peripheral chemoreceptors detect what first? CO2 or oxygen? Oxygen. Central, they can detect CO2, but primarily they are oxygen sensitive. Central chemoreceptors are carbon dioxide sensitive and hydrogen sensitive. But they all mean the same thing, right? If you have a decrease in oxygen, you're going to have an increase in carbon dioxide. All right? That's going to activate chemoreceptors. As far as the respiratory system is concerned, if you have a decrease in oxygen and an increase in carbon dioxide, what's your breathing going to start looking like? You want to get more oxygen in and get rid of carbon dioxide. But this also signals your heart. It also signals your vasomotor control center to increase sympathetic activity, increase blood pressure, so you perfuse your tissues more. Okay, because your body's saying, all right, we have an increase in carbon dioxide and not enough oxygen. We're probably not getting enough blood circulating. So it's going to say, hey, let's get some more blood circulating. While your respiratory system's saying, hey, we need more oxygen and get rid of carbon dioxide. Right? So they work together. That's why they're located in the same space. All right, so this leads to what we call the CN, and this is a really important body response to decreases in brain blood flow. All right, it's called the CNS ischemic response. So if we have, like, let's say a sudden decrease in blood flow to the brain for whatever reason, that's going to cause carbon dioxide to build up, right? Because your brain is very metabolically active. It's going to cause carbon dioxide to build up. That's going to directly stimulate the vasomotor control center. That's going to increase sympathetic nervous system activity, clamp down on blood vessels, increase heart rate, increase stroke volume to raise the blood pressure so that you get more perfusion to the brain. All right? So your brain is responding to a decrease in carbon dioxide by increasing the blood pressure to get more blood to the brain. Does that make sense? Decrease in oxygen or an increase in carbon dioxide.
Okay, you said decrease in carbon dioxide.
Did I? Yes, increase in carbon dioxide, decrease in oxygen. All right, but since it's central, it's going to be more the increase in carbon dioxide because that's where central's fixated on. Okay. Usually we don't activate this because remember, your brain is responding to a decrease in blood flow, and that's what's increasing the carbon dioxide. So it's going to want to increase the blood flow. So usually this ischemic response does not activate until we have pressures below 60. All right, which explains why your mean arterial pressure is between 60 and 100, remember? Okay, so it usually doesn't respond until you fall below 60, because 60 is enough perfusion to get to your brain. Below that, your brain starts freaking out. All right, examples, circulatory shock, bleeding out, things like that would lead to this ischemic response. So if somebody's bleeding out, what would you expect and you take their pulse, what would you expect it to be? High and probably weak. Right, good, really high. If you took their blood pressure, what would it be? Tough question, right? You're like, they're losing blood, but this ischemic response, blood pressure might be high, but that depends on how much blood they lost. Okay? Okay. Atrial and pulmonary artery reflexes. Basically what these say is that if we have low pressure in our atria, that means less blood coming back to the heart, and pulmonary arteries, that can influence blood pressure as well. So how does this happen? Trying to think how to explain this. All right, you have less blood flow coming back to the heart. All right, atria are not going to stretch as much. To the atria, that means, okay, we have less blood volume, so we're going to do something. We're going to tell the kidneys we need more blood volume, right? Because what regulates blood volume in our body? The kidneys. So what they're going to do is they're going to tell the kidneys, I'm doing the exact opposite of what's actually on the slide. It still works that way, though. All right, let's do what's on the slide, just so it makes sense to you. We have an increase in venous return to the heart. Our atria are going to say, all right, we're stretching too much, right? They're going to release something called atrial natriuretic peptide. You also see it called brain natriuretic peptide, BNP, ANP. BNP is actually a marker of heart failure. They're going to release that. That's going to go back to the kidneys, and it's going to tell them, hey, we have too much volume. Get rid of sodium, and by getting rid of sodium, you're going to get rid of what? Water. Your volume goes down. All right? So this is a stretch response that happens in the atria and pulmonary arteries. If they start stretching too much, they send a signal to the kidneys. That signal is ANP or BNP. They're going to tell kidneys to secrete sodium, secrete water, so we decrease our volume. And if we decrease our volume, what happens to the stretch in the aorta? It decreases. Okay. Another reflex. This is the boring. All right. So the exciting part's over. This is the boring part. Bunch of reflexes. I get it. The Bain bridge reflex. All right. The Bain bridge reflex prevents the backflow of blood into our arteries. So it prevents too much backflow of blood. So what this happens is if we have an increase in atrial stretch, so let's say we have heart failure, the blood's not pumping out, so the atria are going to stretch. That's going to send signals to the vasomotor control center that tells the heart, hey, pump faster. Because if we pump faster, that blood is going to exit the atria, go into the ventricles, and get out. Right? So that's a way of clearing the blood out of the heart so it's not backing up. All right? That's the Bain bridge reflex. The good news is that's over. This slide right here basically shows you a flow diagram of all of those reflexes we just talked about. So if you want a good summary slide to come back to, this would be a good one to come back to that summarizes all of those. Just finish. Let's get it done. All right. Everything we've talked about so far has been kind of a short to mid-term response, short to mid-term reflex to regulate blood control, blood pressure. All right. Where did that occur? that occurred in the brain, the ischemic response, that occurred in the carotid arteries, right? That response, those happen almost instantly to regulate abrupt or acute changes in blood pressure. But what if we want to regulate blood pressure over a long period of time? Okay? What regulates blood pressure over a long period of time are our kidneys. All right? Kidneys regulate blood pressure over a long period of time. So, how would we do that? Kidneys control two things, right? They control sodium and they control water. So to regulate blood pressure over a long period of time, if we want to increase our blood pressure over a long period of time, we reabsorb more sodium. Therefore, we reabsorb more water. If we want to decrease our blood pressure over time, we don't reabsorb sodium. If we don't reabsorb sodium, where does it go? Out in the urine with the excess water that's going out too. Okay. I'm not going to hold you responsible for these renal function curves. I don't even want to take the time to explain them. Basically, what I just said is the gist of all of this, right? If we want to decrease our blood pressure over a long period of time, we tell our kidneys to do something with sodium. If we want to increase, we tell them to do something different with sodium and water. Okay? Can we change, for example, the amount of sodium, can we change consciously the amount of sodium our kidneys excrete? Yes. How? Pardon? Consuming more or less sodium. What these say is that if we increase our sodium intake, for example, if I go eat like 3 packs of those like pumpkin seeds, the ones that are white that was salt all over them, if I go and eat 3 packs of those, in order to regulate my blood pressure, my kidneys are going to say, let's get rid of that excess sodium. Okay? And therefore I regulate my blood pressure, right? Because I got rid of that excess sodium, so I'm not retaining water. If I go on a low sodium diet, same thing. Or not same thing, opposite thing, but same concept. Okay? I'm not going to explain the renin-angiotensin because we already did that, right? If we have low sodium, the juxtaglomerular cells detect that, secrete renin, blah, blah, blah. Can you tell me what happens?
Low sodium.
Renin. It is on your test, right? Renin converts angiotensinogen to Ang1. Ang1 gets converted to Ang2 in the lungs by ACE, which is why you take ACE inhibitors, right? Angiotensin 2 is a vasoconstrictor. It causes the release of aldosterone, which reabsorbs sodium. It causes the release of ADH, which reabsorbs water. And you raise your blood pressure. Okay, so that's just a summary of that again. Nothing is new here. This is just a matter of regulating blood pressure. Okay, so the summary of that. All right, this last slide, I thought I got rid of. FYI. This slide, factors which decrease renal excretory function, so factors which decrease our ability to get rid of salt, therefore get rid of water. Increase in blood pressure, we have a decreased renal excretion if we have an increase in blood pressure. Or if we have a decreased renal excretion, this is how it goes. We have an increase in blood pressure, right? If we're not getting rid of sodium, we're holding on to it. If we're holding on to sodium, we're holding on to water. If we hold on to water, we increase blood pressure. If we get rid of sodium, we get rid of water. If we get rid of water, we decrease blood pressure, right? That's what these are saying. Angiotensin II can decrease renal excretion, right? Because it holds on, aldosterone holds on to sodium, ADH holds on to water. That increases blood pressure. That's decreasing renal excretion. Does that make sense? So, increased sodium reabsorption, aldosterone, increase water reabsorption, ADH, over here, atrial natriuretic peptide, increased stretch equals increase ANP, which equals increase sodium excretion, which decreases blood pressure. That's what we already went over. So these are just showing you the factors that will decrease you getting rid of sodium, which will increase blood pressure, or increase you getting rid of sodium and water, which will decrease blood pressure. And that's it. So that was only a couple minutes. All right. I will put it to you that all this last stuff we just talked